सो कार्सिनोमा ऑफ द ब्रेस्ट, इसके बारे में मैंने एक वीडियो ऑलरेडी बनाया हुआ है. आई होप यू हैव सीन दैट वीडियो. द पॉइंट्स आई हैव डिस्कस्ड ओवर देयर आर वेरी इंपॉर्टेंट फ्रॉम द क्लिनिकल पॉइंट ऑफ व्यू and also from the point of view of prevention of carcinoma of breast. So I would first request you to go through that video to get an idea of that, and then I'm not going to go through the points which I've already mentioned. That I'm just going to go through the other important points in this particular video. So this risk factor I've already explained before in that earlier video. And now coming to the most important, which is the molecular classification of breast. Now you know that these two genes which are mutated here are BRCA1 and the BRCA2, which is responsible for the familial breast cancers. And if we talk about the BRCA1, it is associated with the TNBC subgroup. Now let me first talk about this particular chart, so that you understand this part very carefully. So under the molecular subtypes, you have three basic classification. Number one is the luminal type, number two is the HER2 positive, and number three is the TNBC or triple negative breast carcinoma. Now you must understand that in the luminal type, you have luminal A and luminal B. And the differences is that this luminal A basically have got a comparatively lower grade 1 or grade 2, and they are mainly of the tubular variety. And if you talk about the luminal B, then they are of a comparatively higher grade, which is grade 3, and they are mostly of the lobular type. Now here you can see that in the luminal B, the BRCA2 gene is mutated, and in the TNBC or triple negative breast cancer, the BRCA1 is mutated. So this is again a very important point which I want to mention here, that the BRCA1 is associated with the triple negative breast carcinoma, and the BRCA2 is associated with the luminal variety of breast carcinoma, especially the luminal B, rather I would say, because that is what is mentioned here in this chart. Okay, now of course the proliferative rate is comparatively high in case of luminal B type. The metastatic pattern is that they metastasize to the bones. And if you talk about the HER2 positive, here what happens is that here basically we have two types. We have ER positive and ER negative. So HER2 में HER2 तो positive है, लेकिन what about the ER? So under HER2 you again have two types. Number one is the ER negative and number two is the ER positive one. And you can see that this basically happens because of this TP53 mutation. You can give this trastuzumab therapy, which is basically the HER2 new targeted therapy. So coming back to this, basically we have these three categories. I want you to understand this very carefully. Luminal में it is basically ER positive and HER2 negative. HER2 new enriched में it is HER2 new positive, and you have two varieties, either it's ER positive or it's ER negative. And in the basal like or in the TNBC, you have predominantly ER negative and HER2 new negative. Both of them are negative. Okay. So I have told you this, and if you talk about the TNBC, then yes, it is also because of TP53 mutations. It is happening in the young women with BRCA mutations, and the survival with meds is very rare in these cases. So I would just want to mention these points, that a high risk for breast cancer is often present in Lee-Fromeney syndrome because of the TP53 mutation, Cowden syndrome P10 mutation, Peutz-Jeghers syndrome STK11 mutation, hereditary diffuse gastric cancer syndrome CDH1 mutation, and the PAL-B2 mutation. So these things are important because they can be asked in MCQ questions. In all these conditions, there's an increased risk of breast carcinoma because of these genes which are involved. So you must remember these genes and the conditions, and also the point that the risk for breast carcinoma is increasing in all these conditions. Here you can see this chart. The important points are mentioned in this chart which I was talking about, all these conditions and the genes and the kind of cancers that they are associated with. And here you can see that BRCA1 is associated with TNBC and BRCA2 is associated with ER positive cancer. The major risk for luminal breast cancer is estrogen exposure. I have talked about these points in detail in the video in which I have explained about the self-breast examination, whether it's enough or not. I have mentioned about all these points in detail, so you can just watch it from there. And now coming to this pathways of cancer, very important. So the two most important things that you need to remember from this chapter is this particular chart, and the next point is this particular pathway. So here you can see that there are three different pathways. We have the ER positive pathway, which leads to luminal type of cancer. You have the ER negative pathway, which leads to HER2 kind of cancer, and you have the ER negative pathway, which leads to triple negative breast cancer, and you have a mid pathway, which leads to HER2 new type of cancer. So these three main pathways have been identified. This is the most common pathway which leads to the development of the luminal ER positive carcinoma. So you can see that luminal cancers are ER positive. Okay, now the precursor lesions, very important. You must know that which is the precursor lesions of which kind of cancer. So luminal cancer के precursor lesions क्या क्या होते हैं? Number one is the flat epithelial atypia, and number two, it is the atypical ductal hyperplasia. So these two are the precursor lesions of luminal type of breast cancer. Very important MCQ point, बहुत confusing है ये part. ठीक है. If you talk about the triple negative breast cancer, then which is the precursor lesion? It is the p53 signature lesion, which is the precursor. And of course DCIS is present in all three of them. First it will get converted to DCIS, and then from there you will have the invasive carcinoma. I have already told you about the sequence earlier, but the point I'm trying to make here is that which are the precursor lesions. So triple negative breast cancer में precursor lesion है p53 signature, but here you see that if you talk about the HER2 new cancer, there is no definite precursor lesion identified. ठीक है. So if I can just kind of mention here these important points, because they are very important and I just don't want you to miss out on them. Number one, if you talk about the luminal, then which are the precursor lesions? Which are the precursor lesions? Number one is the luminal, number two is the TNBC, and number two is the HER2 type. So HER2 type में there is nothing, right? There is no precursor lesion. Luminal में you have the flat epithelial atypia, and you have the atypical hyperplasia. I already mentioned you about this sequence. What are the criteria for atypical hyperplasia? I've also showed you the image. And about the triple negative breast cancer, you have the p53 signature lesion as the precursor. Okay, now very important point is that here you can see it's mentioned that a possible precursor lesion consisting of morphologically normal cell that overexpress p53 have been identified, and this is analogous to the p53 signature lesions of the ovarian carcinoma. So this is overlapping with the ovarian carcinoma as well. So these are basically the three pathways. Here you can see that there is a PIK3CA mutations and one Q loss, 1 Q gain, 16Q loss, leading to flat epithelial atypia, after which they have a PIK3A mutation which leads to atypical ductal hyperplasia, after which there is DCIS which ultimately leads to luminal kind of invasive carcinoma. If you talk about the HER2 wala pathway, then there is germline mutations in the TP53 which lead to HER2 amplification. There is no precursor, but there is DCIS, and then ultimately leads to HER2 new cancer. And if you talk about the triple negative breast cancer, then there is a BRCA1 mutation which ultimately is accompanied by TP53 mutations which will lead to P53 signature lesion, after which there is going to be BRCA1 inactivation leading to DCIS and ultimately leading to triple negative breast cancer. So this part is very important, and I've also gone through this very important chart. Now why does estrogen cause cancer? This is again an important point to understand, that estrogen increases the local production of growth factors such as transforming growth factor alpha, platelet-derived growth factor, fibroblast growth factor, and regulates the expression of dozens of genes in breast epithelial cells that may directly contribute to tumor growth and development. Estrogen exposure also stimulates the proliferation of breast epithelial cells during puberty, menstrual cycle, and pregnancy, and therefore increasing the number of cells that are at risk for transformation. This is why you see that because of estrogen exposure, the risk increases, and I've mentioned about all these points in details in that particular video. So please go through that because it's a very important video. This point I would like to mention that HER2 positive cancers, they arise through a pathway that is strongly associated with amplification of the HER2 gene on the chromosome 17q. This HER2, also known as ERBB2, is a receptor tyrosine kinase that promotes cell proliferation and opposes apoptosis by stimulating the RAS and the PI3 AKT signal pathways, and the cancers with HER2 amplification constitute 20% of the breast cancer. It may be ER positive or it may be ER negative. The most common subtype of breast cancer in patients with germline TP53 mutations is the Lee-Fraumeni syndrome. So in the Lee-Fraumeni syndrome, you have the TP53 mutations, and the cancer which is most common seen in Lee-Fraumeni syndrome is the HER2 positive cancer. So very, very important. If I can just write it down over here, because this point is very, very important, that in the Lee-Fraumeni syndrome, you have the HER2 positive breast cancer subtype. So if there's a breast cancer in the Lee-Fraumeni syndrome, the type that you see there is HER2 positive. And this is again a question. Exam question means MCQ. This point is again important, that TNBC arises through a estrogen dependent pathway that is not associated with HER2 gene amplification. So TNBC is arising in an estrogen independent pathway. So this particular cancer is not estrogen dependent. So luminal cancers are estrogen dependent, but TNBC cancers are not estrogen dependent, okay? And they are also not associated with HER2 gene. So because you see that is a negative, so ER negative and HER2 negative, so both of them are negative, right? So in the TNBC, it is ER negative and it is HER2 negative. So ER negative matlab it is having no effect of estrogen, and HER2 negative means also the HER2 gene is not amplified here. So now coming to the carcinoma in situ, I've already mentioned about the ductal carcinoma in situ, that it can be detected by mammography, and you can see that the myoepithelial cells are preserved in the involved duct, although they may be diminished. So they are preserved but they are diminished. And why they are preserved? Because obviously this is a kind of a malignant lesion, but then they are not invasive, and that is why to some extent some amount of myoepithelial cells is preserved, right? And here if you see what are the different types, it is comedo type, cribriform type, micropapillary type, and papillary type. So all these things, the types are very important. So what about the comedo DCIS? They have tumor cells with pleomorphic high grade nuclei and central necrosis. This is the comedo type. Cribriform type will have the cookie cutter like spaces, and a micropapillary will have some kind of papillary projections without fibrovascular cores, and papillary will have a true papillae with a fibrovascular core, but they will lack a myoepithelial cilia because these are kind of malignant. Now, what about the Paget's disease of the nipple? It's a rare manifestation of breast cancer that presents as a unilateral erythematous eruption with a scale crust, and pruritus is common. Very, very important point. And the lesion may be mistaken for eczema, but be very careful that malignant cells called as Paget cells are present. That this can be seen in the microscope. And if you see Paget cells, these are basically the malignant cells which extend from the DCIS within the ductal system via the lactiferous sinuses into the nipple skin without crossing the basement membrane. So this is what you can see over here, that if you can diagnose these cells, then it is basically pointing to a DCIS. And if you can treat DCIS, then there is nothing better than that, because DCIS has not yet progressed to invasive carcinoma. So DCIS arising within the ductal system, and that can extend up to the lactiferous duct and into the skin of the nipple without crossing the basement membrane. So you can see that underneath there's a DCIS, one duct is involved by that, and now these cells are kind of seeping through and moving out, and this is why you get a cross and itching basically. So the malignant cells will disrupt the normally tight squamous epithelial cell barrier, allowing extracellular fluid to seep out, and that forms an oozy scaling crust. So see this a very important point, that a palpable mass is present in almost 50% of women with Paget's disease, and almost all these masses prove to be invasive carcinoma. तो मतलब सोचो, just imagine that means this carcinoma has already progressed to invasive carcinoma. 50% of a Paget's disease is ultimately presenting with a palpable mass, means they have already kind of having this invasive carcinoma. This is so very sad. So if untreated, a woman with low grade DCIS will progress to invasive carcinoma. This is something which you can easily understand. And now if we talk about the lobular carcinoma in situ, I've already told you that these cells are kind of discohesive because they have this loss of E-cadherin and mutation of this gene, which is the CDH1 gene. And what kind of cells do you see here? You see mucin positive signet ring cells. Invasive carcinoma developing in women after LCIS are threefold more likely to be lobular carcinoma, obviously, right? And now if you talk about the infiltrating carcinoma, it is basically known as the ductal carcinoma, no special type, okay? So the diagnosis that we usually write is invasive ductal carcinoma, no special type. This is what the diagnosis we usually give. They mainly present as hard, irregular, radiodense mass. They have a desmoplastic stromal reaction. They produce a characteristic grating sound similar to cutting a watered chestnut. So this is very important question for your MCQ based exam, that lobular carcinoma में क्या होता है कि cells are arranged in a discohesive pattern or single file pattern because of the loss of E cadherin, because of the mutation in the CDH1 gene 16q loss. And you can see these are the cells, and you can see how these cells are arranged in a single file pattern. So this is a single file pattern. All these cells are arranged in a line, right? And they're discohesive. Here also you can see all these cells are kind of lying in a line, and the cells are not kind of attached to each other, right? This is basically the invasive breast carcinoma of no special type. We write it as IBCNST, and we have a special score here, which is the Nottingham score. You can see this invasive carcinoma is graded using this Nottingham histological score. Now, what is this score? You have grade 1 when it is a well differentiated carcinoma. They grow in a tubular or cribriform pattern, and they have a small uniform nuclei, and they have a low proliferative rate. This is grade 1. So basically there are three very important points. Number 1 is the tubule formation, number 2 is the nuclear pleomorphism, and number 3 is the mitotic rate. So based on these three important points, there are some points which are given, and once it's calculated, you find that ultimately that will direct you to whether it's a low grade or a high grade lesion. So here you can see this is basically the one I was talking about, the tubule formation, nuclear pleomorphism, and mitotic count. You can see that these are the categories and the scores are given, and now once you add up the score, you have a total score, and if the total score is 3 to 5, it's grade 1. If it is 6 to 7, it's grade 2, and if it's 8 to 9, it's grade 3. And here you can see this, in this image you can see this is grade 1, because you can see that this is a grade 1 well differentiated carcinoma showing frequent tubules with small monomorphic nuclei, and this one is grade 2 with which is moderately differentiated. They show less tubule formation and some solid nest of cells with pleomorphic nuclei, and here you can just see that it is just sheets of cells and there is no tubule formation. So because the tubule formation, if the tubule formation is more, then the score is less, means it is a comparatively better grade, well differentiated grade 1, right? So if the tubule formation is more, then the score is less, and therefore ultimately it will fall under the grade 1 category. There are various types of these cancers. You can just classify them as lobular carcinoma and mucinous carcinoma. In the mucinous carcinoma, you see that the tumor cells are arranged in clusters and small cells of islands within large lakes of mucin. Then you may have tubular carcinoma, you may have papillary carcinoma, and apocrine one, then micropapillary, then carcinoma with a medullary pattern, metaplastic carcinoma. So what is metaplastic carcinoma? It basically includes spindle cell carcinoma and matrix producing carcinoma. These carcinomas have a gene expression resembling those of myoepithelial cell. Then you may also have this secretory carcinoma and inflammatory carcinoma, because this inflammatory carcinoma has a characteristic gross appearance caused by extensive plugging of the lymphovascular spaces of the dermis, and they tend to have distant metastasis. The breast becomes swollen, there's erythema and skin thickening, and this kind of has a very poor prognosis. The outcome depends on the features, biological features of the carcinoma, the molecular type or the histological type, and the stage. So all the things are important, along with the lymph node spread. So all these features will kind of predict the prognosis of these patients. Lymph node metastasis, if you talk about this, then axillary lymph node status is the most important prognostic factor for invasive carcinoma. Very important. This axillary lymph node status, this is the most important prognostic factor for invasive carcinoma. So you can see all the important prognostic factors are mentioned here. It's just that you have to go through this. There's nothing much to understand here. The risk of axillary lymph node metastasis increases with the size of the primary tumor, but size is also an independent prognostic factor. This T stage is something which you have to memorize. MCQs can be framed from here. So stage 1 is less than 2 centimeter, stage 2 is 2 to 5, and stage 3 is more than 5, or any carcinoma with skin or chest wall involvement, or inflammatory carcinoma, and 4 is any size of carcinoma. Another point is that in the absence of adequate control, some breast cancers can advance to carcinoma Carcinoma enquirus, which means carcinoma of the breastplate, a dreaded complication of the infiltration of the skin and ulceration. And now if we talk about the male breast cancer, then this gene is important. You must remember that the BRCA2 gene is playing an important role in the male breast cancer. And now if you talk about the stromal tumors, in the stromal tumors, you have two tumors. Number one is the fibroadenoma and number two is the phylloid tumor. So you know that fibroadenoma is of two types. You have the interlobular and you have the intralobular carcinoma. Now very important point that both this fibroadenoma and phylloid tumor, they have mutations in the MED12 gene. Very important point, very important MCQ points. Okay, so this diagram is basically of the intralobular type of fibroadenoma. The ducts are comparatively compressed because the stroma is proliferated so much. So the epithelium may be surrounded by stroma, which is the pericanalicular pattern, or compressed, which is in the intracanalicular pattern. So in the intracanalicular pattern, basically the stroma is compressing the ducts, but in the pericanalicular area, the stroma will not so much compress the ducts. The ducts will be partially open. Okay, now talking about the phylloid tumor, similarly here also there is MED12 mutations and TERT mutations are also present here. These points are important for MCQs, and these are basically larger lesions. They were bulbous protrusions because the word is leaf like, okay, due to the presence of nodules of proliferating stroma covered by epithelium. So this is what you can see over here, that compared to fibroadenoma, there is increased stromal cellularity and overgrowth, giving rise to a typical leaf like architecture. So there is an increase in the stromal cellularity even more than the fibroadenoma. The phylloid tumor is distinguished from fibroadenoma on the basis of higher cellularity, higher mitotic rate, nuclear pleomorphism, stromal overgrowth, and infiltrative borders. The low-grade benign lesions resemble fibroadenoma but are more cellular and are mitotically active. So this is basically the point that you must remember, that how does it differentiate from fibroadenoma. Now the last most important point, an important MCQ point, is that the lymphatic spread is rare in case of phylloid tumor, and therefore the axillary lymph node dissection is contraindicated. Very important MCQ point, that in case of phylloid tumor, the axillary lymph node dissection is contraindicated regardless of the grade of the phylloid tumor. This is the last MCQ of the day. And with this, we come to the end of this chapter. I hope you enjoyed watching this video and learned something from me. And if you like my content, then please consider subscribing. So I'll be back with the next episode very soon. Till then, take care, keep studying, and thank you for watching.